Okay, all right. So let's start our session tonight. And for those who are new in our session today, welcome to First Aid AMC. I am Dr. Arshan Ahmed. I'm actually one of the tutor in the First Aid AMC. So I'll be doing the MCQ of some of the recent like sample questions so that you know like how the questions needed to be solved in the exam and what are the tricks and traps. Okay, now these questions are not AMC oriented. These are sample questions so that you know how to solve questions. Please remember that. And always I say that you need to have a very good theory knowledge to answer questions in any exams you appear in your life, whether it's AMC, whether it's USMLE, whether it's PLAB, whatever you are going through, you need to have a good theory knowledge. Okay, do not rely on any questions or any previous things. That's not actually a good idea to do so. Always try to have a good theory knowledge. So before you start solving questions from QBank, from many other sources, it's vital to have a good knowledge on theory. So how you can improve your theory? You should have a good knowledge on your John Murtagh. You should get a lot of knowledge from other websites Australia is providing freely. So you have RSCGP, you have Red Book, you have RCH, Essay Health. So there is a lot of options and free reading stuffs are there. Go through those things to make your knowledge first. Okay, that's very important. So let's start with the sample question. So this is our first question. Who is having problem with hearing? Anyone, is the voice is good? It should be. Dr. Seat, let me just help her. Cool. So let's start. And normally when we take classes, usually you guys need to answer or you guys need to write your answer in the chat box. And then usually we don't ask anyone to unmute because it can make a lot of noise in a lot of participants like this. So always write in the chat box your answer, your questions and everything. All right, in this way, it will be a noise-free class, but I will be able to answer your questions. Cool. So let's start. 42-year-old women trying to conceive, 172 centimeter, 130 kilo, has been trying for pregnancy for 10 months. Husband having normal sperm analysis, what to do next? So if you look at here, the BMI is pretty high. So she's really obese in here. Okay, if you calculate the BMI, or even by the look of it, 172 centimeter having a 130 kilo body weight, it's a lot of like, it's a very high BMI, right? In this case, you know your first clue that this patient is an obese patient. And what's the question is all about? Subfertility, right? Patient is trying to get pregnant, but unfortunately, she is unable to do so. And what is the time duration? 10 months. Remember, more than 35-year-old having trouble with conception, you call it subfertility if they are trying for 6 months, okay, having usually like no like frequent intercourse in the usual fertile period time, and still they are unable to conceive, then it's subfertility in more than 35-year-old patient. Less than 35, usually it's needed to they need to try for at least 1 year to say that they're infertile or subfertile. We don't use the term infertile anymore, it's subfertile. Okay, so this is a 42-year-old. So she is subfertile. She has been trying for 10 months. And what is the reversible factor in here that you can see? The reversible factor, like first of all, we need to always consider the husband or the partner problem. So partner is good. So sperm analysis is normal. If sperm analysis was not done, the first thing that we would ask her to do is to do this sperm analysis. But that has been already done. So the next thing is, what is the reversible thing here we need to look at? I know that this is a very advanced aged pregnancy, 42-year-old. It's an advanced age, right? Like if we wait a longer period of time, there is a possibility that her chance of getting pregnant will gradually decrease. That's right. But if you have a reversible condition that can profoundly impact on someone's fertility, you need to minimize that first, whatever age it is. Otherwise, that adverse effect or that adverse factor can also impact the assisted method of pregnancy you are going to offer to her for this advanced age. Obviously, if this patient was not obese, you should recommend her assisted pregnancy, because by the time it's more than 41, she falls under the criteria of assisted pregnancy. But this one makes a little bit of tricky here. So if we look into some of the guideline, then we will see, always try to find your own answer. I have given you many link to have a read, but this one, the red one, will be a little bit more explanatory. Let's see. So impact of obesity on fertility in women. So it's a very long reading. I want to read the important one. So obesity and overweight involves an abnormal excessive fat accumulation that obviously impact the health of a body. There are lots of other adverse effects that we are not worried about. We're mainly worried about this thing. Let me have a look. So it's a good guideline to read. This one, obesity and infertility. So we know what is infertility or subfertility. It's although many obese multiparous women are able to get pregnant despite their obesity, there is an increased prevalence of infertility in obese women. The studies also demonstrated that the duration required to achieve a spontaneous pregnancy is increased, and pregnancy rates are decreased in obese women. So obesity causes infertility through various pathways, mainly impaired ovarian follicular development, embryo development, implantation. Everything is usually will be impaired for it. And also it affects your hypothalamus pituitary gonadotropic axis. So this HPG axis actually helps your estrogen production and all the female hormone production. So that pathway or that axis is going to be suppressed. And when it gets suppressed, you get your anovulatory cycle or irregular cycle, and you have menstrual dysfunction and ovulation. And if you don't ovulate, you don't get pregnant. So that's actually the pathophysiology of obesity causing infertility or subfertility. Now, this is quite important because for these women, assisted pregnancy was a good way, right? But for her, we cannot use that. Why? Because of the obesity epidemic worldwide and its association with infertility, a large number of overweight and obese women are treated using assisted reproduction technique. However, poor reproductive outcomes are encountered in ART. Okay, and this is particularly related with central adiposity or PCOS. Women who are overweight or obese have a poor outcome following IVF than women with normal weight ranges. And you can see there is an association between obesity and poor embryo quality in women below 35 years of age, and young obese women have a less chance of cryopreserved embryos. Now, you don't need to know all these things. I just want to show you that these are the impact that happen. So what is the treatment if a person is infertile and she is also obese? It is difficult to treat this infertility in obese women because the obese women have a lower chance of conception following ART because they require a higher dose of gonadotropin. They respond poorly to the ovarian stimulation and high risk of miscarriage is there. So that's why weight loss among overweight and obese women has been shown to improve reproductive outcome, including infertility. So the basic thing is weight loss should be primarily offered to the anovulatory, overweight, and obese women. Okay, however, the effect might not be that much dramatic, but it can increase the possibility, it can decrease the risk. That's the important part. So the conclusion is overweight and obese patients should be informed about the importance of pre-pregnancy weight reduction, should be encouraged to lose weight before the treatment to reduce poor obstetrical outcome. Okay, now we usually would not delay the ART treatment for this patient particularly. Okay, she's 42, but obviously before we go for ART, we will recommend, and they are asking what to do next. Next means that what we are going to do next for her. The best next option for her will be weight reduction. You guys are right. Okay, very good. So weight reduction would be the first option, but the most appropriate thing for her would be recommending assisted pregnancy later on. Okay, good. So that was mainly the relationship between weight reduction, obesity, and subfertility, and also how we can minimize the adverse outcome in an obese woman who is going to use ART for their reproduction. Okay, cool. Uh, as I can see, our participants is already 99, and I don't think anyone will be able to join after that. Um, just give me a second. Let me see that if someone is having problem. All right. So I think no one will be able to join after this one. So I'll just give it a post in our group so that no one feels the difficulty. Okay, cool. Sorry for that. The next one. You've got a 13-year-old boy, Tanner stage 2, bone scan showing 18 months behind his age. Physical examination is normal. What is the diagnosis? So you've got a 13-year-old boy who is Tanner stage 2. Tanner staging is actually used for the development of puberty in a kid or in a boy or girl. So there is Tanner stage 1 to 5. 5 means that they are well developed sexually and their maturity is all good. 13-year-old boy should have Tanner stage 5 at this time. But as you can see, the growth is not that much. Okay, that's not the issue. The main thing in here you have to look at is the bone scan. Bone scan shows that the boy is 18 months behind the age, which means there is two type of age. One is bone age, another is chronological age. This boy, chronological age is 13-year-old, but his bone age is less than 18 months, which comes to this chart, which will be a really good for you to memorize. If you look at this chart, If bone age is less than chronological age and they have normal physical examination, normal all other finding, that should be constitutional delay. And in case of abnormal, like any abnormal physical examination, then we can think about any other endocrine related causes like growth hormone deficiency, something like that, or chronic systemic disease, etc. Now also, now you can easily differentiate the familial short stature, because familial short stature, their bone age and chronological age is equal. So what is the difference mainly between these two terms, familial short stature and constitutional delay? Now, the main thing is like some patients will grow like in a slower pace, but eventually they will attain the normal growth. Like say like I was one of the like smallest kid in my class when I was at 6, like in class 6 or in year 6, I was like the smallest kid. Okay, but when I came up to year 10, I was like one of the tallest, or you can say that at least the minimum average, the taller I was at that time, which means that I had I had a slow growth and I catch up later on, but I attained the normal growth. Okay, so this, yeah, Dr. Sim, growth spurt, that's the correct term. So growth spurt, someone's growth spurt is very high and rapid. Someone's growth spurt will be slow, but eventually they will get it. But patient with familial short stature, they are genetically short. So they will not attain that catch-up growth later on. They will be shorter. So that's the main difference. So their bone age, chronological age is same, and they are familiarly short stature. But constitutional delay means by this time, now he is 13-year-old, his growth spurt is not that good in relationship to the other boys in his age group. But eventually, like in 2 or 3 years' time, he will attain that growth. So that's your constitutional delay. Clear? So it's very easy to find out during your exam also. You just need to remember that familial short stature, bone age will be equal to chronological age. Constitutional delay, when bone age will be less than chronological age. Also, this is a very good link here. You can give it a read. It's Wikipedia, but sometimes Wikipedia also can give you a good explanation. So this constitutional delay is a term describing a temporary delay in the skeletal growth. That's why bone age is a little low, and thus height of a child with no physical abnormalities causing the delay. Okay, short stature is mainly, it's a type of growth pattern which you inherit from family. So this is the difference. Clear? So our answer in here will be constitutional delay. So you already understand that physical examination normal, that exclude your option E, growth hormone deficiency, hypothyroidism, okay? And physical examination normal also exclude developmental delay. And developmental delay is totally different. Okay, developmental delay means like a person at 4-year-old, he should do these things. At like at 1-year-old or 1 year to 18-month-old kid should walk. That is development. Okay, we don't use developmental delay in a 13-year-old boy. It's either constitutional delay, familial short stature, etc. And another one is familial short stature, that should have like your bone age should be equal to chronological age. Clear? Any confusion here? Now we say abnormal, like a person who has growth hormone deficiency, they will have characteristics of that growth hormone deficiency, right? So like there will be features of growth hormone deficiency. Everything will be smaller for them. Hypothyroidism will have specific features. So that abnormal features will be there. When they say physical examination normal, they are actually ruling out all these things, all abnormal findings. Clear? It's very unlikely, who asked Dr. Meherin, it's very unlikely that they will give you growth hormone deficiency in these sort of cases. Because growth hormone deficiency is like, normally they cannot give you in a, just give me a second, I think it's a little bit noisy surrounding me. Okay, it's fine now. So they would not give you any growth hormone deficiency questions in here, nor hypothyroidism, because in these cases, it's hard to give these sort of answers. Growth hormone deficiency is totally different thing. We can discuss it today, but it will just take a time and we'll lose our time for other questions. But growth hormone deficiency, normally the physical examination might have something like the body parts looks smaller, something will be smaller. Okay, so they will give those sort of findings to us so that we know. So normally, yeah, so it's a dwarfism, you can say. So mainly everything will be smaller. Like usually what happened, they have like delayed rate of development of facial bones. Facial bones will be smaller, slow tooth eruption. They will have like lack of bone longing or elongation. Okay, poor nail growth. So all these things will be there. High pitched voice. Some of the features of growth hormone deficiency will be there. So obviously, it will not be a normal physical examination. Now, Tana 2 in 13 years old, it's delayed puberty. Okay, the term is, have a look at the term first. Constitutional delay of growth and puberty. This is the exact name. So this person is having constitutional delay of growth and puberty, all. Okay, this is the exact term that should be used in here. So in 13-year-old, he should have the puberty. But again, if physical examination normal, we can still wait. It's not like for 13-year-old having Tanner stage 2 is like totally abnormal. We don't, Dr. Faril, we don't do FSA's LAs first. We don't need to do because we wait. We usually wait first. We don't do investigations for delayed puberty. Initially, we wait for to catch up. We see if there is any abnormal findings are there or not. If we get abnormal findings, then we can do those investigations. And usually, just with the X-ray, you can do this like bony age. Bone age you can even find with a bone like a bone X-ray. Okay, but sometimes if you do the bone scan like they have done, it will give us a definitive bone age. So we don't need to do FSAs, LAs or anything at this time. Yeah, we always like, because first of all, we need to know that what type of problem he is having. We need to know the bone age first. Like if you see here, you need to first find out the growth velocity. To get the growth velocity, you need to know the bone age first. When you know the bone age, then you can go for your next investigation. Like you cannot say precocious puberty unless you know that bone age is more than chronological age. So bone age should be the first investigation rather than going to the hormonal assay first. Clear? Next, 43-year-old women a year ago had done a breast ultrasonogram showing simple breast cyst without any atypical feature. Now the cyst was bigger and biopsied and malignancy was reported. She was angry that why did not they do biopsy last year to know its malignancy? What to do? So you see that, tell me one thing, that simple breast cyst, is it cancerous or not? I need to know, like, what is the percentage? Normally, what is usual thing? Usually no. Simple breast cyst without atypical feature usually doesn't get transformed into a breast cancer. But yeah, everything is possible, can be in a slightest percentage, it can happen. But without atypical feature, just a simple breast cyst, 43-year-old, unlikely to get cancer from the cyst. So, so 1 year ago, she had those diagnosed. Now cyst has got bigger, biopsy and malignancy reported. Now she's angry that why the biopsy was not done last year. So your options are: tell her it was a simple cyst and there has been no indication of biopsy last year. Tell her your previous doctor was wrong. Refer her to surgeon for breast surgery. Obviously, you will not refer her without answering her question. Tell her I can't answer that until I consult a specialist in that field. You don't need to consult a specialist to answer this question. Never choose options like this, like where you need to consult a specialist or where you need to refer a patient first. Usually in MCQ, referral or consultation is not the initial thing you do. Tell her the malignancy is probably not related to the cyst. Obviously, it can be related to cyst. We cannot say that because the cyst now got bigger and got the malignancy. So you can rule that out. Now, between A and B, you already understand that it should be the A, right? Because choosing B doesn't answer her question. Tell her it was a simple cyst. There has been no indication of biopsy last year. Now, again, to get our mind clear, we need to see if it is right or not. So go to the RSCGP guideline. And this is a very good guideline of all the breast lump. Obviously, give it a read. You will find many answers from here. So breast cyst. A breast cyst is a localized collection of fluid in the breast. It's common mainly around the women of 30 to 50 years age group. All right. Now, cyst can be single or multiple. It's mainly related to a hormone and mainly it fluctuates during the menstrual cycle. Cyst after menopause is usually unlikely. Any breast cyst after menopause, you should consider cancer because cyst usually should disappear after menopause because it's hormone responsive. After menopause, you don't have the hormone, so very unlikely to get a cyst at that time. So if you get a cyst after menopause, do biopsy first. Imaging. Cyst usually not very well visualized on a mammogram, so usually you should do an ultrasound first to see if it is a cyst or it's a solid lesion. If you get a cyst, then you can aspirate and send the cytology of the fluid to rule out any cancer. Now on ultrasound, usually they can say that is it a typical cyst or is it a simple cyst with typical feature or is it a simple cyst with atypical feature. Okay, so if it is an atypical feature, which means that you might get some thick wall, you might get some abnormal echoing in the ultrasound, that time you should do further imaging. especially FNAC or biopsy. See this one, management. Cysts that are asymptomatic show typical benign cystic feature on imaging, require no treatment. Patient can be reassured that lesions are not malignant, and they usually don't increase the chance of developing one. They require no specific follow-up. Women with cysts that are symptomatic can be offered aspiration for symptomatic relief. A palpable lump that has the features typical of a simple cyst on ultrasound doesn't require aspiration for confirmation of diagnosis. So you already understand ultrasound can actually say that do we need to do anything else like a biopsy. But cystic lesion that shows atypical or complex feature on imaging, they should get a aspiration followed by FNAC, or like usually you do an FNAC, you can take, you can do the aspiration, or you can do aspiration cytology also if you want. So breast cysts are benign. Imaging, especially ultrasound, can usually distinguish cyst from cancer. Okay, so usually this is our answer here. So we'll say that tell her it was a simple cyst and there has been no indication for biopsy last year. So that should be your correct answer in here. Yeah, we don't need to do any follow-up according to the RSCGP. If it's a simple breast cyst asymptomatic and ultrasound says that it's not a cancer, there is no suspicion, we don't need to follow up. Give it a read also to see the guideline, okay, and you will get many other conditions answers. Next, children with a ventricular tachycardia ECG presents with dizziness. Now obviously those who are our student, you guys already did the ECG class with us. You know how to find out the ventricular tachycardia, and most of you also know, I know. So ventricular tachycardia ECG, that's one thing. There is two terms. One is asymptomatic, another is symptomatic. This patient is symptomatic and it's a child. So pediatric patient having a ventricular tachycardia and having symptoms that requires treatment. They are asking for what is the next appropriate treatment for her, for this child. So if you look at, this was the ECG. So obviously it's a VT, you can see, and it's a monomorphic ventricular tachycardia. You can see. Okay, I'm not going into the ECG today because it will take a lot of time. So this ventricular tachycardia ECG, so they will not obviously write it like this, like children with ventricular tachycardia ECG. They will write that, well, you have got a patient like who is like a 6-year-old kid coming to you with dizziness. You did the ECG, you find out this ECG, what's your treatment? So you need to find out that this is a ventricular tachycardia first, and then you want to treat this kid. What should be the treatment? Now, usually don't consider DC cardioversion initially for the children, okay, unless they say that like child is having hypotension, confusion, all right? So the indication of DC cardioversion for any age group is one, your hypotension, that means shock, unstable patient. Then if the patient is having any altered mental status, which means confusion, having breathlessness, having chest pain. So these four means unstable. Dizziness is not confusion. Dizziness doesn't mean this patient is like having confusion. Any patient having arrhythmia, they will have dizziness. Okay, that's the most two common symptoms for arrhythmia is, one is they will get palpitation because it's a racing of the heart, and obviously they will feel a little bit of dizzy. Okay, so this is not an unstable patient. we can rule out DC cardioversion first. Now, most of you, I can see that you are choosing adenosine. Adenosine is SVT. And this is not SVT, this is ventricular tachycardia. It's a little different. Now, yeah, if it's a pulseless VT, then we go for cardioversion. But they haven't said anything about the pulse, so we'll not think that it is a pulseless VT. All right. Now, let's see what e-medicine has told us. I had quite a lot of research about this one. No, this is a quite like this ECG is obviously VT, not a SVT with aberrancy. So therapy may not be needed in an asymptomatic patient whose VT pattern suggests a low risk of sudden death. So if it's asymptomatic, it's okay. We can just look at it. Come to the pharmacological therapy. Although antiarrhythmic drug therapy can suppress spontaneous arrhythmia, although it can help individual patients, some of these can increase mortality in selected adult and pediatric patients. Mortality rate typically increase when overall risk of the arrhythmia is less than the pro-arrhythmic risk of the drug. That means if you use the pro-arrhythmic, like anti-arrhythmic drugs, it can increase the mortality even more than the arrhythmia patient is having. So it's mainly problematic in pediatric patients. So for pediatric patient, it's better not to use any anti-arrhythmic medication first. So although digoxin is approved in infant, it lacks specific antiarrhythmic properties. All other agents, despite the current use, are not approved for use in young children. So forget about amiodarone because this is an antiarrhythmic drug. Okay. Antiarrhythmic drug therapy is further complicated because no single drug is ideal in all settings. Beta blocker with intravenous esmolol or any of the oral preparation is a good initial choice for nearly all form of ventricular arrhythmia. So for a child, we'll go for this one because this is not contraindicated. And in all form of ventricular arrhythmia, it can help. Okay, so better to start with something safer. Adenosine is used in supraventricular tachycardia, same Valsalva maneuver used in supraventricular tachycardia. Obviously, there is quite a lot of difference between a SVT and VT. SVT occurs in your atrium. Ventricular tachycardia occurs in your ventricle. So it's quite a lot of difference between SVT and VT. Okay, so we just don't treat everyone with adenosine. All right, so that's one of the guidelines that we have found out from the e-medicine. Now we'll go to the RCH, supraventricular tachycardia. So for your Royal Children Hospital, RCH, this is a very, very good guideline for any pediatric questions for AMC. All right, everyone follows this. So supraventricular tachycardia, we can find out here. So in supraventricular tachycardia, older children will come to you with chest discomfort, palpitation. They can also even have dyspnea, dizziness, etc. So if you look at here, This is the SVT, how it looks like. You can see here. So this is a narrow complex tachycardia, and you can see the RR interval. These are all regular. So regular rhythm, narrow complex tachycardia, that's SVT. Okay. Consult cardiology urgently if tachycardia is broad complex or irregular. Broad complex, we need to think about VT, and irregular, that's atrial fibrillation. Management. This management is for SVT. Someone asked me that it's according to the RCAs that we need to give adenosine for every patient. Can you show me, Dr. Vagia, where exactly it's written in this way? Okay. Don't refer me for any QBank. QBank is like not absolute. Absolutes are the guideline. Okay. QBank is written by some person. So don't refer for by any QBank. QBank, there are lots of QBank which gives false ideation. Okay. We don't give QBank explanation. We give explanation according to the guidelines. All right. So normally in SVT, what we will do, if child is shocked, that means these are the criteria, as you can see: hypotension, impaired mental state. Impaired mental state means patient is confused. That means patient is not responding to you. Dizziness is not confusion. Okay, dizzy means that you are feeling lightheaded. That's the dizziness. Then you proceed for DC cardioversion. If child is not shocked, then we treat intravenous adenosine. Remember one thing, in case of SVT in children, if children is stable, you will try the Valsalva maneuver first. The Valsalva maneuver that's usually better is like immersion in a cold water or giving some ice water uh, splash. So that's mainly the usual Valsalva maneuver or vagal maneuver that you do. You start with the vagal maneuver. Valsalva is if the child understand and it's old enough, then we can try Valsalva. But vagal maneuver can be anything. Like usually we would do this ice water immersion. That should be the better one. That doesn't help, then you go for adenosine in a stable children. All right, we'll keep it as a atenolol or beta blocker for this moment. I'll have a look at your uh, life in the little lane. I don't know that if it is there or not. I'll have a look, but at the moment, because I can't see any other guidelines saying adenosine for ventricular tachycardia, better to stick to the e-medicine guideline. Okay, so the basic thing is if it's a SVT, we will start with if the child is stable or unstable. If child is unstable, we go for DC cardioversion. If child is stable, then we will try the vagal maneuver. Not helping, we go for IV adenosine. In case of ventricular tachycardia, again, if it's a pulseless VT, that's cardioversion, obviously. If unstable child, cardioversion again. But if it's a stable child but symptomatic, we will go for beta blocker initially. Yes, unstable SVT, any unstable thing, especially if it's the unstable SVT, you should go for DC shock first, right? Valsalva, there is no specific age group that we can start with. Usually, like if the child is like, I would say like, if the child understand what to do, how to do this Valsalva maneuver, then we can give it a try. We don't need to give it a try in a 4-year-old kid who will not understand how to do the Valsalva. But a 12-year-old, yes, we can give it a try. But why we will try Valsalva when just a ice water immersion can help? All right, let's move to the next question. I'll have a look to Dr. Faril link, okay? Because we need to, like, I've kept about 70 questions here. If we move in this pace, there will be only 10 or 15 questions which we have discussed. 17-year-old, previously healthy boy presented with a one-day history of vomiting, lethargy, impaired consciousness. On examination, severe dehydration, labs given RBS 22 millimole per liter, pH 7.1, bicarbonate 8, potassium 5.6. What is the next immediate management? So you've got a 17-year-old having, what is the diagnosis? When RBS, that means random blood sugar, is 22, it's a DKA. Very good, Dr. Vagia. So DKA, right? Diabetic ketoacidosis. So diabetic ketoacidosis and also symptomatic, you can see patient is having vomiting, lethargy, impaired consciousness, and with severe dehydration. What is the first thing you do in a DKA patient? Obviously, you do IV fluid hydration, right? So it's the normal saline first. After normal saline, what you would do for this patient? Insulin infusion, right? So insulin infusion would be the next thing to do. After you start the insulin infusion, then you see what is the potassium. Give it a read from here, diabetic ketoacidosis. It's very well written here, but obviously you should start hydration as soon as possible. Next question, Dka scenario with metabolic acidosis. Let's assume the same scenario and patient having metabolic acidosis. After fluid resuscitation, what we are going to do? So we already got our answer, right? We will go for insulin. Sodium bicarbonate should not be used unless it's a ICU, okay? And it's not initially you will try that. So don't try sodium bicarbonate, resonium. Potassium supplementation, obviously, when you start insulin, insulin can obviously lower down the potassium level in the blood. You will check it every hour or more frequently. If anytime it goes below 3.5, you will give the potassium supplementation, okay? But otherwise, we'll just monitor the patient. The first thing is hydration. Next thing is insulin infusion. The third thing is the potassium. Next, patient presents with symptoms of depression and anxiety. You prescribe sertraline 50 milligram. After 2 months, during review, patient says he has only mild improvement. What is the management? Now, this is a very, very good question. So you have got a patient who is having depression, anxiety. You started sertraline 50 milligram. The next question is, usually, how much time it needs to get the effect of antidepressant. Usually you can say like, yeah, like there is like lot of guideline according to it. Some guidelines says 2 weeks, some guidelines say 2 to 4 weeks, some even say 6 to 8 weeks. Okay, like maximum if you want to hear, that's 6 to 8 weeks. Okay, that's according to your JM. But RSCGP or other Australian guideline usually say 2 to 4 weeks. Okay, but maximum, if you want to keep it in your mind, that within 2 months, antidepressant that should start working. Patient should not say that it's only having a mild improvement. Now, what else we can do for him? Do we want to increase the dose or continue the same dose for another 8 weeks? No, we will not continue the same dose. Change to another drug. This is also an option, or adding something else like a benzodiazepine, lithium, antipsychotics. There are many other options. What do you want to do first? Now look at this guideline. This is an Australian guideline. So we'll start always with a first line antidepressant. The first line antidepressant is mainly SSRI, so sertraline, fluoxetine, paroxetine, those. Usually you will assess the response after 2 to 4 weeks of treatment. Continue the usual initial treatment if the patient responds well. But if there is no initial response, increase the dose. If there is still no response after 2 to 4 weeks of treatment at the higher dose, then you switch to a different drug. Okay? So main thing is that if partial response or no response, you increase the dose first. Then again recheck in 2 to 4 weeks time. But if it's still not improved, then you switch to a different drug. Now, if you switch to a different drug, will you start with the SSRI or other antidepressant? That's the main issue. So first increase the dose, then change to the same class of SSRI, or then change to other class or SNRI. So if an alternative antidepressant is indicated, the new drug may be from the same or a different class. There is currently little evidence to guide the choice of an alternative treatment. In particular, if the initial treatment was with SSRI, there is little evidence that changing to another class of antidepressant is superior to using another SSRI. If there are severe or unacceptable adverse effects, switch to an antidepressant with a lower propensity to cause those side effects. In my perspective, if one SSRI doesn't makes effect, better to use another form. Usually venlafaxine is a good one. Many doctors use venlafaxine if the initial SSRI doesn't work. So we can try for a venlafaxine or any other SNRI. So in here, what we will do, remember one thing, the sertraline, we start with the 50 milligram normally, but in 5 to 7 days time, we increase the dose to 100 milligram. And patient usually continue to take 100 milligram, not 50 milligram for 2 months. So patient already getting lower therapeutic dose. So you should obviously increase the sertraline dose here. Maximum dose that we can give is 200 milligram sertraline. Next, BMI chart is given. A 11-year old child with BMI 25, asking about his weight interpretation from chart. So, so this is a growth chart actually, nothing else. So in the growth chart, they will provide you with a chart in the exam, and you need to put the child age with the BMI. Okay. Now let's have a look. So this is one of the growth chart. So those who are asking about this one, the first one, as you have seen just now, there is no proper guidance about should we change to another same class SSRI, or should we change to SNRI, and that's from an Australian guideline, ETG complete. So ETG complete or ETG guideline is used everywhere in Australia. So if they don't say that which one we can choose, usually it case by case, it depends on the doctor who is prescribing. You can try the same class, you can try the another one. Most of the time we try venlafaxine. That's usually better to choose if one SSRI is not helping. But again, we can change to another class. This another class changing is usually happens if someone is having side effects, like patient is responding well to the SSRI, but that SSRI is causing side effect. Then usually you switch to the another drug of the same class. Okay, but if SSRI is not improving moods at all within 2 months, very unlikely that another same class drug will help. So better to try with the SNRI or any other form of medication. Now look at this one. There are many chart like this, growth chart. Now this chart is mainly BMI for age. That's very important to look at. So what is the BMI of this patient? So BMI is 25, and this is an 11-year-old. Okay. So you need to first look at, in the x-axis, this is the age. So this is an 11-year-old. And we need to know, let's say that this 11-year-old child is a girl. Okay. So 11-year-old girl with a BMI 25. So your BMI is given here. So this is the BMI in the y-axis. What is the BMI? 25, right? So 25. So this is the 25, and this is your 11. So you need to go up along this line. If you go up along this line, what you find out? So this is the line, right? And what is this line? This line is above 95th. If it is above 95th, what is the interpretation? All right, now you got it. Like if it is above 95th percentile, that is obese, right? I haven't seen like morbid obese. Usually in children, we don't use the morbid obesity. Okay, so have you understand like how to get this 95, 97? Yeah. So this one actually we are looking for. So if it is BMI for age more than 95th percentile, that's obesity. 85th to 95th, that's overweight. Less than fifth percentile is underweight. Okay, so that chart that we have used, it's a little confusing. It will be a better chart, I think, like if we get a CDC chart, then that chart will, I think they will not write anything like a 97th or third percentile. They'll use this fifth percentile, 85th percentile, and 95th percentile. Okay, that's why there was a little confusion, but it's clear up now. So in this case, if we are looking for BMI for age and we use the CDC chart, and yes, it's right that usually above 2 years old, we use the CDC chart. Below 2 year old, we use the WHO chart. Okay, so for a 13-year-old, what is the age of this kid? 11-year-old girl will obviously use the CDC chart, and this CDC chart, if we interpret, if it is above that chart, it was in between 95 and 97th, right? This the interpretation. If it is more than 95th, so what will be our answer? So it was initially, actually it was right, so it should be obese. Okay, not for the confusion. I think there was a confusion about this third and 97th percentile for height. Okay, all right, we'll keep it in this way so that it doesn't make any confusion later on. So for CDC chart, growth chart, less than fifth percentile, it should be underweight. All right, and if you look at here again, so in between 5 and 85, that's normal. Okay, 85 to 95, that's your overweight, and your more than 95, it's your obese. For CDC chart, we'll keep this one. Okay, yeah. So for weight, the normal weight is between 5th to 85. All right, 5th to 85, that's normal. Above 85, it becomes either overweight or obese. So between 85 to 95, overweight. More than 95, that's obese. Clear? Cool. The next one, a girl picking her eyebrows because she feels tense if she doesn't do it. What's the diagnosis? So this is a psychiatric question. This is a OCD, impulse control disorder, anxiety disorder, kleptomania, thyroid disorder. All right. Now, first of all, what is obsessive compulsive disorder? Obsessive compulsive disorder means that you will have an obsessional thought, and then you will have compulsive behavior. The obsessional thoughts are like, you think that if you don't count 20, your mother is going to die. So your mother is going to die if you don't count 20. That's your obsession. That's an abnormal persistent thought. And the compulsion is the rituals that you do to relieve from that obsessional thought. The ritual is like you are counting to 20 every time when this thought comes up in your mind, right? So that's your OCD. All right. So in this case, yes, actually what we should prefer in this case, if trichotillomania is not in the option, obviously trichotillomania falls under previously in DSM-4 criteria. It was it was in impulse control disorder, otherwise classified elsewhere. So that was the term they used to define trichotillomania. And now in DSM-5, they have actually, yes, it's included under OCD and related disorder. So if OCD is in the option, I think it's a better idea to keep it in the OCD option. That's right. Okay, so we'll keep it under OCD rather than impulse control disorder, because DSM-5 is the good, or you can say is the new guideline. DSM-4, it was under the impulse control disorder. So according to the DSM-5, we think like it's good idea to keep it under OCD rather than kleptomania, rather than anxiety disorder or impulse control disorder. Okay, keep it as a OCD. That should be the better option. But again, like if trichotillomania is in the option, we will choose that one. The kleptomania is a term in which a person actually feel anxious when they cannot steal from others. So it's a disorder of stealing from others, and usually it's not like a very like rich objects, it's small petty things they usually steal. Okay, and once they steal those smaller objects, they feel that their anxiety is relieved. So that's your kleptomania. It's not trichotillomania. Anxiety disorder doesn't fall into that. Tourette disorder, it's a kind of tic disorder also, you can say. There is motor tics and vocal tics. If someone has both motor and vocal tics, we usually diagnose it as a Tourette disorder, which means that their motor tics means that they will do some unnecessary, unusual movement or fidgeting of their hand, any part of their body. And the vocal tics is that some unusual sound they use. Okay, if someone has both motor and vocal tics for more than 6 months, then you can diagnose it as a Tourette disorder. If there is only motor part of it, no vocal part, then diagnosis will be motor tic disorder. There is simple motor tic and complex motor tic. If just only single part of the body is involved, like they are just moving their single hand, that will be a simple motor tic disorder. If they use multiple part of their body, like both hand, both legs, so when it's multiple, then it will be a complex motor tic disorder. So these are all usually very commonly asked in the exam as well. Make sure you understand what each of these term means. Okay, so this picking hair, picking eyebrow, or picking anything, it could be, the picking can be from himself or herself or someone else also. So any of this picking falls under trichotillomania. According to DSM-5, we'll keep it under OCD, not the impulse control disorder. The next one is a patient with major depressive disorder treated with sertraline for 4 months without any improvement. What do you want to do for this patient? You want to start with dothepin, venlafaxine, sodium valproate, lithium. Yes, it's a good idea to start with venlafaxine. As I said, like if someone has not been improved in 4 months, there is very unlikely they will get improved. We don't know what type of dose he was using. If it was a subtherapeutic dose, we can try increasing the dose, but in this case, the only option is venlafaxine. Sorry, venlafaxine would be a good option. Okay. 70-year-old patient came complaining of episode of difficulty in speaking and heaviness of the right side of the body few days back, which resolved spontaneously in 30 minutes. What is the most appropriate investigation for this patient? So you've got a 70-year-old patient having difficulty in speaking, so aphasia, heaviness of the right side of the body. Probably it's like a hemiplegia, which resolved in 30 minutes. What is this condition? TIA, right. So this is a TIA. What is the most appropriate investigation in a TIA patient? That's the question. So you want to do a ECG, CT brain, carotid Doppler, echocardiogram, or a MRI. So every suspected TIA patient should get these three investigation as soon as possible. So a person who has TIA, there is very high risk of getting stroke within 7 to 10 days. In any hospital, usually if a person comes to you, like a 70-year-old is a very high risk patient, comes to you with a feature of TIA, the first or the most appropriate investigation that you would do is a CT scan of the brain. You might not get anything, all right, but still you need to rule out a stroke because we don't know that what's going on. So first thing is a CT scan of the brain that you need to do. That's the most appropriate one, not a carotid Doppler. Obviously, carotid Doppler should be done as well, but according to the JM, we would go for CT scan. Then we will go for carotid Doppler, ECG, and the echocardiogram. Normally, from where usually this, I would say, like TIA usually happens. If it's a amaurosis fugax, like in which a person actually have a slight, for like 10 minutes, they don't have, like, like for 10 minutes they lost their vision in one eye. And then again they resolved. That's amaurosis fugax, that also mini stroke or TIA. In that case, from where usually this amaurosis fugax can come up, usually most of the time it's either carotid. So it could be a carotid plaque which ruptured, and then there is an emboli which blocked the retinal artery, and you develop that amaurosis fugax. So that's one of the commonly one. So carotid artery stenosis. To check for the carotid artery stenosis, you do the carotid Doppler. And according to the level of obstruction, we can actually treat those patients by doing a carotid endarterectomy. Another one, most importantly, can come from a atrial fibrillation. So if a person having atrial fibrillation and then patient can develop some thrombi in the atrium, and then there is an emboli can dislodge, and the same thing can happen. So mainly you do an echocardiogram to rule out that thrombi. You do a carotid Doppler also to rule out carotid artery stenosis. The most important thing that you do is CT scan. CT scan should be done for every patient who is a risk of getting a stroke, especially for the 70-year-old patient. So if it's like, if it's a amaurosis fugax, yes, we should go for a carotid Doppler, but according to the Australian guideline, no, not ESR. ESR is usually if you want to rule out temporal arteritis, don't bother with the ESR, for it's totally different thing. So in case of TIA, amaurosis fugax is also a TIA, and hemiplegia, aphasia, these are all a subtype of TIA. TIA can develop any part of your body. It can involve your eye, it can involve your, like, speech, it can involve just a motor component like hemiplegia. So anything which resolved within 24 hours, that's TIA. The guideline is like, in case of TIA, the most important thing that you want to rule out is that is this patient can have a chance that there is a ischemia now, or you can also find out any previous ischemia by doing a CT brain. Yeah. So initially, like we would go for the CT brain first. After CT brain, we will go for carotid Doppler. We will go for echocardiogram. But CT, without doing a CT brain, going directly to the carotid Doppler, no, we'll not usually go for carotid Doppler initially. And this patient came after like 70-year-old patient came complaining of episode of difficulty in speaking and heaviness of the right side few days back, which resolved spontaneously in 30 minutes. What is the most appropriate investigation? Now, yes, that patient actually presented few days, like patient had this episode few days back, right? Still, any patient having TIA within 7 to 10 days, if it's 7 to 10 days duration, we would go for a CT brain first. Okay, because we don't know that if there was any ischemia which was resolved or not. The main issue is like, I'll show you a RSCGP guideline. I think it was in the RSCGP, and also in the hospitals mainly in the hospitals. If you get a patient with the TIS symptoms, usually within 7 to 10 days, but most of them usually comes as soon as possible. Usually we'll go a CT brain done first, because that's the first thing we will do. And then because carotid Doppler will need some time, we'll need to like refer the patient, all these things will be done. But the CT brain should have the first thing to do to rule out a stroke. All right. Like in a TIA patient, whatever it is, if it's the next most appropriate, if it's the most appropriate, we will go for a CT brain first. If CT brain doesn't give us any finding, then you can go for MRI. But usually CT brain should be able to find out in few days time, CT brain should be able to get you what you want. But because if it is a stroke, CT brain should be able to find it in few days time. It should be there in few days time. If it was within few hours, then yeah, you might miss it in CT brain, but in few days you should get it in the CT brain if it is there. The bottom line is, like in case of TIA, we'll initially, or most appropriate, whatever it is, we'll start with a CT brain first, and after CT brain, then usually comes two other investigation. One is carotid Doppler, another is echocardiogram. Okay, usually we'll start carotid Doppler if it's a case of emesis fugax, because that's more likely to cause it. If it's a case of atrial fibrillation patient having a TIA, we'll go for echo first. Okay, so it depends on what type of patient it is. Any patient having a TIA, patient should be admitted to a stroke unit. Okay, and if it's only TIA, there is nothing in there like how we will manage this patient. If it's a carotid ischemia, that you got carotid artery stenosis in the Doppler, and then you should start the patient with antiplatelet therapy, which mainly you can give aspirin. But if aspirin and dipyridamole is in the option, that usually the better outcome. So either aspirin or clopidogrel or aspirin dipyridamole. If aspirin dipyridamole is the option, we will choose this one. Okay. 75-year-old lady came with anhedonia and insomnia. She was assessed with geriatric depression scale, a screening tool used to diagnose depression in elderly. The test would be negative and normal if the score was under 5 out of 15. So test is negative. So usually we do geriatric depression scale for to find out that if this elderly patient depressed or not. It's not 100% effective. Obviously, the history and assessment is vital part. But this can give you an idea that if the patient having depression or not. Test has 70% sensitivity and 90% specificity. Positive predictive value 50% and negative predictive value 90%. That means the test is pretty good. The score for this patient was 4. What to do for this patient? So you want to start antidepressant, admit, further assessment with detailed history, repeat the test in 3 months, reassure her she has no depression. What you want to do? Now, very tricky thing, like they have given you in a way that you will say that, well, the patient doesn't have any depression, but you cannot just say that she doesn't have any depression. Reassure her. She has 4 score, right? Obviously, she's having the main 2 important symptom of depression. Anhedonia, that means loss of interest, is one of the very common finding for depression and insomnia as well, right? You have got 2 of the important finding. Now you cannot just say that you don't have any depression, just reassure. It's a better thing that to find out, because you should do further assessment always in these cases. Because if you ask her other symptoms, like other symptoms of MDD, you might able to get it. So further assessment in case of psychiatry, especially depression, psychosis, is always better. And if you get some time, go through this geriatric depression scale and scoring. Okay, so you can get the idea here also. It's also written in here that just by using this scale, you cannot totally rule out depression or you cannot totally confirm depression. Okay, your assessment is the vital part along with the score. 15-year-old boy living in the street presents with laceration to his arm during a fight. During history, he discloses that he is bisexual and has multiple sexual partner and asks for STI screening. What will you do next? 15-year-old boy living in the street. So it's an independent, right? Do you want to inform parents? No. If it's an independent, you don't inform parents. So rule that out first. Do you need to inform Child Protection Authority if it's independent? Again, no. So you want to educate him about safe sex, or you want to do a STI screening? That's the question. So in AMC, always explanation, education, or like like talking with the patient mainly is always a good option to choose. And there is also like, are you going to do STI screening for this patient or not? That's the question. Yes, you should, obviously. If this is because for more than 14-year-old, it's a mature minor, and more importantly, he is independent, living in his street. So obviously, we'll do a STI screening for him. Okay. Now the question is like, are we going to do the STI screening first and then educate him? Now STI screening will take some time to come up. What if the patient goes home, goes to the street, have some unprotected sexual intercourse, okay, because you did not educate him about the safe sex when you did the STI screening, and they're asking that what you're going to do next. So the bottom line is always it's a better idea to give the education first. Okay, education, because obviously you will need to counsel the patient. Counseling is the must part in any consultation. So you need to educate him, obviously, and you're going to do the STI screening also. And safe sex education is always very, very important role or part of your consultation, especially in this age group, young adult. Okay. So better option, if they're asking next, better option to educate him. So in any time, that doesn't mean like choosing safe sex education doesn't mean that we are not going to do STI screening. Obviously, we have to do STI screening for him. He is high risk. Okay, we're not just sending him with a safe sex education. The question, we need to understand the question. If the question asks next means what is the initial part we are going to do. Obviously, like a person living in a street, bisexual, multiple sexual partners, obviously he will need a safe sex education. Okay, so first thing is education followed by STI screening. A sex worker came for a sexual health checkup. What will you ask to guide management? Very, very interesting question. So, sex worker coming to you for a sexual health checkup. What will you ask to guide your management? Number of partners, injecting drug, sex of partners, use of condom. Very good. It's the best thing that will guide you to the management is the use of condom. That means she knows how to do the safe sex. And that means that if she's using safe sex, you don't need to do a STI screening unless she asks for it. So your management depends on this, that if she's practicing safe sex or not. If you look at this question and the previous question, is pretty much same. All right. That means all are actually related to the safe sex practice. So kind of makes sense. "14-year-old girl lives with her family, recently sexually active with boyfriend, visits you for contraceptive advice. She tells not to inform her parents. What is the next management? 14-year-old, mature minor, but she is independent. Are you going to inform her parents? No. For OCP advice, never ever inform the parents. They can decide what they want if because they are 14-year-old. Perform mandatory reporting for child sex abuse. Okay. Give her OCP advice uses of condom for study. Ask her about her relationship, identity, and age of her sexual partner. Tell her that she needs her parents' permission. She doesn't need parents' permission, no inform about the partner parents. Mandatory reporting not needed unless you know about her relationship. So very, very important thing that you do, any mature minor, especially less than 18-year-old girl, less than 18-year-old, having sexual, like recently sexually active or having sexual intercourse and asking for OCP, before you provide OCP, the first thing that you need to know that what is the partner identity, what is the partner age, and what is the relationship with the partner. The guideline about this one is that less than 18-year-old girl cannot have sexual activity with someone who is more than 2 years older than them. So that's why age is important. Also, less than 18-year-old cannot have sexual activity with someone who has authoritative role, like teacher, like anyone who is acting as a authority figure, because they can manipulate. Like the manipulation can come up within their relationship. So very, very important. Anytime less than 18-year-old having sexual activity, the first thing that you need to know that what is the identity of the partner, what is the age of the partner, and if there is any other relationship, like if it's like a guardian, or if it's a teacher, or like a trainer, okay, any of these sort of things cannot have relationship, and that time you need to do the reporting. Usually it's illegal to do this, like do sexual activity if someone has more than 2 years gap. But after 18-year-old, they can do sexual activity with anyone they like. Okay. So that's why the first thing that you do, they're asking the next management, you ask about the relationship, identity, and age. If everything is good, then you give her OCP. Clear? 32-week pregnant lady came with 800 ml blood loss and severe abdominal pain. Fundus is tender and symphysiofundal height 36 centimeter. Fetal heart sound not heard. Patient has tachycardia and hypotension. After fluid resuscitation, what is the next appropriate management? 32-week-old having PV bleeding, severe abdominal pain, and tender fundus. What is your diagnosis? Abruptio placenta. Good, Dr. Mehek, Dr. Naila. So abruptio placenta, and you can obviously find out that the symphysiofundal height is 36 centimeter, whereas it's 32 weeks pregnant. So obviously it's more than the gestational age. That also says that there is bleeding going on still now. The more important thing you need to look at, any person having abruptio placenta, that there is a very high risk that intrauterine fetal death can happen. And that is given in here, that fetal heart sound is not heard. If you cannot hear fetal heart sound, normally you just need to confirm it with a Doppler. If Doppler also says that there is no heart sound, that means you even don't need to do an ultrasound to confirm the dead fetus. Okay, and again, if it's the intrauterine fetal death, you don't need to do a urgent cesarean section. So no need of ultrasound, no need of cesarean section in this case. The next thing is that, do you want to do the induction by giving an prostaglandin and then go for amniotomy? You don't actually need to do so, because if you look at the handbook case, it's a similar thing. 39 weeks gestation, having abdominal pain, vaginal bleeding, okay, and BP is 95/50, pulse rate is high. Fetal hearts cannot be hard on auscultation or Doppler. Okay, cervix 3 centimeter dilated, fully effaced. Which one of the following, in addition to immediate resuscitation, is the most appropriate step? According to your handbook, it's obviously a severe placental abruption resulting in fetal death. When the baby is already dead, cesarean section is not needed. An amniotomy is usually all that is required, as uterus will be very irritable at this time. You don't need to give prostaglandin to ripe it. Normally uterus will be very irritable, and if you go for the amniotomy, spontaneous labor almost always follows. Vaginal prostaglandin is unnecessary, and it is unlikely an oxytocin infusion will be required. Ultrasound examination to confirm the diagnosis and confirm fetal death is also unnecessary in view of clinical and Doppler findings. Whatever is the age of the patient, that doesn't mean, like it's a 39 or 32, the diagnosis is same. Okay. So in this case, we don't need to go for anything. It's a clinical evidence. It's all right. If we get a clinical evidence of fetal death, that's all right. We don't need to go for ultrasound for here. No need. Okay, because if someone is having abruptio placenta and you cannot hear the fetal heart sound, and I don't know, like, if it's a complete question, the complete question, maybe they will also write it as a Doppler. Okay, usually fetal heart sound, if they say that it's not hard, it means that they are implying fetal death, and they're asking what you want to do after resuscitation. Obviously, after resuscitation, rather than going to an ultrasound, no need of doing an ultrasound. Go for the amniotomy for a spontaneous induction of labor or spontaneous onset of labor. No, if clinical examination, Dr. Sefi or others who is having trouble with the ultrasound, for abruptio placenta, if in the exam they write that fetal heart rate or heart rate is not hard, think it that it's a fetal death. Okay, keep it as a amniotomy. Don't go for an ultrasound. It's not needed. If you are confused between that, is it a placental abruption or placenta previa, then you go for it. Okay, so just doing an ultrasound to find out if this person is having IUFD or not at all needed. A person in 32 weeks having tender uterus, severe abdominal pain, and gestational, like fundal height is more than the gestational age, everything is placental abruption. Why we would need, do we confirm diagnosis of placental abruption by ultrasound? No, we don't. Or even intrauterine fetal death, even if you like if you get abruptio placenta and fetal heart rate is not hard, it's most likely fetal death. We don't need to do that. It's a clinical diagnosis. We don't need to do an ultrasound for that. Yeah, if it's a placenta previa, then you should do an ultrasound, obviously, because your management depends on the grading of placenta previa, and that only you can do by an ultrasound. 10-week pregnant lady came with vaginal bleeding. On examination, os is open. Some fetal tissue is seen in the os. After gaining IV access, what is next? So I've got a 10-week pregnant with a vaginal bleeding, open os, fetal tissue is there. So obviously it's incomplete abortion. For incomplete abortion, what is your next thing that you should do after gaining IV access? Cross-match, DNC, remove the retained product at the os, ultrasound, coagulation profile. Remember, I know that most of you will have a problem with the cross-matching and removing the retained product. Remember one thing, a person having incomplete abortion doesn't mean that always you will need to give blood transfusion. Okay? If they say like there is a massive bleeding there going on, and if patient is in shock due to incomplete abortion, obviously we will go for a cross matching. But whatever you do after IV access, it's best to remove the retained product as soon as possible, because the bleeding will not stop unless you remove this retained product. Whatever you do, you give blood, still patient blood pressure will fall, because it's causing a cervical shock. It's not mainly due to the bleeding patient is having shock, is the cervical shock, because this fetal tissue in the os causing cervical shock, and unless you don't remove this one, nothing is going to happen. Okay, so if the very important thing is to remove this retained product at the os, is the first thing that you do after gaining an IV access. Obviously, in this case, if there was an IV fluid, that would be a good option to choose. Like after gaining IV access, we should start an IV fluid, and then we can remove the retained product. A patient has chest discomfort for an hour, and he is okay now. ECG and trop normal. Let's say this is a 50-year-old patient. Age is very important in chest. What to do? Repeat ECG and trop in 2 hours. Continuous ECG monitoring. Reassure and send home. Angiography. Now for an hour, 50-year-old patient having chest discomfort, you did ECG trop. The first ECG first trop is normal. You never ever send a patient home without at least doing second troponin. So you should always repeat troponin. So initial, like in 1 hour, it might be totally normal. After 2 hours, it can be 6,000. We have seen patient like that. Okay. So obviously you should repeat ECG and troponin. Every patient, especially if it sounds like cardiac chest pain, and if the age is like 50 year, 60 year, even 40 year, we should always repeat it. We'll continuously repeat it. It's not like always it will need 6 to 8 hours to get it. Sometimes even within 2 hours, you can get it. It's not like that we do drop after 6 hours of onset of pain. No, we don't do after 6 hours. What if this patient is having a MI? And will you wait for 6 hours to diagnose MI? No. Whenever the patient having chest pain, you will obviously get an ECG and you will do the troponin first. What if initially the troponin is high? We don't know that. We'll do it at the onset of chest pain. Whenever patient comes, we'll do this as soon as possible. And then we'll go for, then we will repeat it again in 2 hours. Sometimes even like if it's high risk patient, we will wait for 6 hours or 4 hours at least. A 27-year-old pregnant lady never had cervical screening test. Present with postcoital bleeding in second trimester. On a speculum exam, cervical ectropion and a laceration is found. What to do? So never had cervical screening, patient having postcoital bleeding. Postcoital bleeding in this age group of always, this is a concerning factor, right? And it's the second trimester, that's fine. On a speculum, you have got ectropion and a laceration. Now, whatever you get in a speculum, that cannot totally rule out your main differential. What is your main differential in this patient? Cervical cancer, right? So every patient who is having this postcoital bleeding in this age group should have a co-test first. Co-test means both you are looking for HPV DNA as well as the reflex-based LBC. So both you will do here at the same time. So co-test will be our most important thing. Now let's say co-test is normal. Are you clear? Will you stop there? Or will you still send this patient for a colposcopy? Now, the guideline is if it's a single episode of bleeding, and your examination normal, co-test normal, you can wait. But if it is more than one episode, yes, then you should obviously send for colposcopy, even though co-test is normal. We who asked about that? Yes, Doctor. What was the name? Dr. Firoz, yes, we do HPV DNA as a screening test. Like if someone comes to you for a cervical screening test, then you will only do HPV DNA. But this is a postcoital bleeding, you should do co-test. Patient planned for total hip replacement, and when patient asked about the complications of the surgery, surgeon got irritated and told her extensive list of complications, including can die due to anesthesia. Now patient got scared, thinking about not going for surgery. As the GP, what will you do? Offer referral to different surgeon, refer to anesthetist to discuss the anesthetic complication, report surgeon to APRA, call the surgeon, ask him to apologize to the patient. So obviously you can see that this surgeon got irritated, and obviously he made it like a lot of extensive complication, which make the patient scared. In any time this sort of confusion arise, you should try referral to a different surgeon. That's right. We don't need to call the surgeon or ask him apologize or not even APRA report. Not needed. Just offer referral to a different surgeon. That's right. Good. A patient needed a surgery for a spinal canal stenosis. Okay. Question. Refer to anesthetist to discuss the anesthetic complication. As the GP, it's not our task to refer to the anesthetist. It's the surgical team usually will refer to the anesthetist. The surgeon who is going to do the surgery, because it will be in a hospital, the hospital anesthetist will do the anesthetic checkup. Okay, the main issue is not about the anesthetic complication that he is worried about. It's mainly he's worried about the risk of surgery, that with the surgery he can die. Okay, and it's not a mandatory report that you need to just like report the surgeon to APRA. Now, obviously, what is the ground of reporting in here? There's the thing. He did not say anything wrong that yes, any patient can die during surgery. Risk of surgery explained not only by the anesthetist, but also mainly by the surgeon. Because surgeon will be responsible, the first responsible person will be the surgeon, next anesthetist. Okay. Usually, anesthetic checkup will be done. If anesthetics clear the patient for surgery, surgeon will explain and take consent for the surgery. But it's not our duty, like a GP's duty, to refer to anesthetist. Okay, GP will refer to the surgeon. Surgeon will ask for the anesthetic consultation. Okay. So, Dr. Seed, anytime in this sort of situation, always better to ask him to reveal the truth. I would go for D first. So you will tell him to reveal the truth, and if he doesn't, then you will inform APRA. Okay. Yeah, Dr. Sheher, you are right. Like he is scared to die from anesthesia. Now, still, if the main issue in here is not the anesthetic, okay, it's not like what if I refer to the anesthetist to discuss the anesthetic complication, okay, and anesthetist said no, yeah, you can die, and it's not like your like it's not like everyone will die from anesthetic complication. There is a possibility. The anesthetist said in this way. The thing is, will this patient go to the surgeon or not? Because he's already scared the patient for dying. Okay, most of the patient will not go to the surgeon. In my perspective, because these are ethical questions, right? There is no guideline anywhere. Usually, what is done in here is this is the part. Normally, as a GP, I would not refer to anesthetic for surgery because it's not my job. My job is to, because I think that this patient needs surgery, I will refer to the surgeon. Surgeon will ask for the anesthetist. If anesthetist clear the patient, then surgeon take the consent for the surgery and proceed for the surgery. That's the usual procedure, right? But obviously, I don't need to like refer to anesthetic. It's better because obviously patient needs to hear from the surgeon first, because the person who is going to do the surgery, patient should rely on that person first. And if that person is scaring him, obviously he's not going to do surgery by the surgeon. Yeah, that's a good question, Dr. Faril, that if they haven't done it before, how we can sure that they will inform on our request. Now, that's not actually our concern that they haven't done it before. Obviously, I didn't know before. Now, when I know, I am the person responsible if I don't tell it to the immigration or to the registration board, right? I will be equally responsible not for not telling or not revealing it. So now obviously you will have a look, you will give some time to him that yes, you should now, as you told me, and I, this is my part of job to keep my registration, that I need to inform the APRA. If you don't, then I have to do it. So good thing, like, this is called stepwise approach. It's not like you know that you just report it. It's not like this. Always is better to first ask the person that why did you do that, or why didn't you reveal it earlier? Was there any reason? Find out the reason that why they haven't done it. And if it is not relevant, then ask them to reveal it. Still they don't, then you inform. Next, a patient needed a surgery for a spinal canal stenosis. He came to you and complained that physiotherapist told her that the surgeon that we suggested to her had a high failure and errors in surgery, was scared to go to the surgeon. What to do? Call the physiotherapist, tell him why did you make such comment. Usually we don't do that. Tell the patient that choosing the surgeon is part of our job and physiotherapist has no role in it. Usually we don't do that also. Tell the patient to go to surgeon and talk to him about his concerns. Report the surgeon to APRA. Always remember, talking, explaining, educating. These are very good option to choose in exam. So in here, if you got a concern, talk with the surgeon. Find out what's going on. Then if you want to report, you report. 15-year-old boy presented with headache, nausea, vomiting, neck stiffness, and rash. What to do as soon as possible? Headache, nausea, vomiting, neck stiffness, rash, everything is given. So it's a meningitis, right? Meningococcal meningitis because it's a rash. What do you want to do as soon as possible? Lumbar puncture, blood culture, meningococcal PCR, CT. If I add another option of antibiotic, then from that, what you would choose? No, not antibiotic. Remember, no, antibiotic is not, obviously antibiotic is priority, but blood culture is best, because if you give antibiotic, then do a blood culture, it may not reveal any organism. Okay, so you might not, you will just give a broad spectrum antibiotic. Always it's best to take the culture first before giving antibiotic if it's possible. Whatever it is, if it's rash or not, even if it's a meningococcal meningitis, we will try to take the blood culture if possible. Sometimes, if you are in a GP practice and you might not have that facility to take a culture, you can give the first dose antibiotic, send the child to the hospital. Hospital can still take a blood culture and go with the antibiotic. But if you have the facility to take the culture, you will obviously take the culture first. Yeah, it will not delay antibiotic, but it doesn't mean that you don't have 5 minute time to take the culture. Okay, you will always try to take the culture if it's possible. 22-year-old pregnant women with breech presentation, going for elective cesarean section, BMI 20, no risk factor, no past medical history. What to give for prevention of DVT? Now look at this. This is a very good question actually. So you've got a patient with a breech presentation, pregnant, elective CS, BMI 20. BMI 20 is not bad. No other risk factor of DVT. So she is not high risk for DVT. Okay. Now what you want to do? You want to give heparin, enoxaparin, GCS or hydration. Let's have a look. This is a very good thing to know about. Okay, let's have a look. Maybe this one. Thromboprophylaxis. Okay, let's see this one. Risk factor for VTE. So, no, thromboprophylaxis in these pregnant women, non-pharmacological thromboprophylaxis. All women require early ambulation unless contraindicated. All women should have graduated compression stockings fitted pre-operatively. So this patient is going to have the elective cesarean section. So pre-operatively, she will get graduated compression stocking. And women who is having elective CS with no other risk factor for VTE doesn't need any thromboprophylaxis with low molecular weight heparin or Clexane. Okay, so only compression stocking is all that we need to do. Let's have a look this one. So cesarean delivery VTE prophylaxis. All women should receive mechanical sequential compression device, which means this GCS. If someone has previous history of DVT or PE, then both mechanical and pharmacological prophylaxis should be given, and that should be continued for 6 weeks postpartum. Okay, so that's mainly the guideline that you need to remember. Hydration is a part of a treatment, but if they're asking for prevention of DVT, it's better graduate compression stocking rather than only hydration. By giving hydration, it means that we are not giving anything else for prevention of DVT. We're just doing hydration. But obviously, with hydration, she will need a GCS. No, every pregnant. See, there's the guideline. Just now we have just to read it. All women with a cesarean delivery, VTE prophylaxis, all women should have this mechanical compression device pre-operatively until they become ambulatory. Okay, so obviously we'll go for early mobilization, but until they become ambulatory, we'll start her with this GCS. Same with the other guideline, no risk factor. Usually we go for this like hydration, mobilization, but during this time, because she's going to have this elective cesarean section, so during this pre-operative up to ambulation, she will get this GCS. Okay, so both of these guidelines actually the same thing, and this is Australian guideline also, so we can take that. Postpartum mother awake all night, not letting to take her child away, afraid of swapping and stealing her baby, checking everything in the room, wanted to go back home. What to do? What is the diagnosis? Postpartum mother having the thoughts that someone is going to steal her baby, which is a delusion. And that's the term we call postpartum psychosis. Dr. Rida, good. Not OCD, postpartum psychosis. Postpartum psychosis, what should we do first? That's the question. Admit her in the psychiatry ward, discharge her, or just give some medication like olanzapine, diazepam, sertraline. Any patient having a postpartum psychosis should be admitted in either general psychiatry ward or better to be in a mother baby unit if there is anything like that. Okay, so that's the guideline. Always admission first, followed by antipsychotics. So let's see that something from here. So treatment will be provided in a hospital in either a psychiatric mother baby unit or general adult psychiatric unit. Usually you will start with medication like olanzapine, like any other antipsychotic, but many times that doesn't help, then even you need to go for the ECT. If sometimes they ask you that what is the first test or most effective treatment for postpartum psychosis, that should be ECT. All right, so admit her first with psychosis, admit first. She keeps checking her baby, starts in thoughts to harm baby. His obsession is mother getting overprotective, manipulating her baby away in psychosis. She had a thought to harm the baby. No, it's not like that. Usually, we can also keep it as a like overprotective mom, but in here, if you look at here, not letting to take her child away, afraid of swapping and stealing her baby. Swapping and stealing, this is a kind of delusion. Okay, this delusion comes up like abnormal belief that someone is going to swap, someone is going to steal. It's not always that thoughts of harming the baby that does only say that it's psychosis. Okay, obviously it's overprotective, and that's why it's the best thing to admit her in a psychiatry ward in a mother baby unit, because then the mother will be able to be with the child, and then she will feel fine. Women who have postpartum psychosis may have a range of following symptoms. They can have confusion, disorientation, concentration can be affected. There is like they can feel foggy, severe anxiety or agitation that you cannot stay still, variable mood, insomnia, delusions or thoughts that are not true and that are often paranoid, that the hospital staff are spies, that your partner is an imposter. Okay, these thoughts may seem bizarre or silly when you are well, but in the middle of the illness, they can seem real. You can have hallucination, impaired sensation, strange sensation, thoughts and or plans to harm yourself or your baby. So anything can happen. It doesn't mean that we'll have these thoughts of harm should be there, hallucination should be there. Any of these things can lead to the psychosis. We should consider psychosis first because this is an emergency situation and it has like a range of presentation. Yeah, it's a paranoid delusion that she is having at the moment. She actually doesn't fulfill the full criteria of psychosis. She is in between, like impending psychosis, which means that she is obviously having postpartum depression. On the top of that, she is going to develop psychosis later on. Okay, this is actually the in the way of psychosis she is going. In this time, if we can treat her, this will be the best way. And obviously, you are not going to discharge her. You are not going to give any other medication first. This patient obviously need to be admitted. A patient with melena went through endoscopy. A duodenal ulcer was seen in the biopsy. H. pylori diagnosed and triple therapy was given. What to do for follow-up? Urea breath test in 6 weeks, repeat endoscopy in 6 weeks, H. pylori serology, endoscopy, duodenal biopsy. So duodenal ulcer was seen. For duodenal ulcer, we don't need to do a repeat endoscopy. For gastric ulcer, you do a repeat endoscopy in 6 weeks. And already you diagnosed H. pylori, so why would you do H. pylori serology again? So obviously these are not needed. An endoscopy now, duodenal biopsy not needed. So this patient needs follow-up, so we'll just do a urea breath test. All right, duodenal ulcer, gastric ulcer, usually with the symptoms is pretty hard to differentiate. They would not give you peptic ulcer because peptic ulcer means both duodenal and gastric ulcer. They would not give it to you because then this question doesn't, as someone who had an endoscopy, this it can obviously say, is it a duodenal or gastric ulcer? It will not be a peptic ulcer in the exam. Okay, obviously if they want you to follow up, they will give you, is it duodenal or gastric? If gastric ulcer, then we do repeat endoscopy for follow-up. If duodenal ulcer, for follow-up, we do urea breath test only in 6 weeks. Now, gastric common is duodenal ulcer, obviously. Gastric ulcer is not common at all. Usually, with the symptoms, it's not possible actually. Sometimes you can get like usually patient with gastric ulcer usually get pain like in the epigastrium when you eat, all right? Or and in case of duodenal ulcer, when you eat, the pain usually gets resolved. So sometimes the eating pattern can help you to diagnose, but it's very, very vague. Like this vagueness is that much that you can never ever say that is it a duodenal or gastric ulcer just by the symptom, because presentation is more or less same. We have to do the endoscopy to say that is it a duodenal or gastric. All right, I think we'll finish it here tonight. There was still a lot of other cases to discuss, but I think we're running out of time today. If we get some time anytime soon, again, we will take another class on these questions. Okay, it was good today because many of you are very aware of these questions, and by this sometimes there can have some confusion, and it's always good to solve the confusion by the links, by the guidelines, and etc. Okay, it's always important to do so because no one can say that they are 100% sure about any of the answer. It's never possible. There are confusions, and the confusions we can only solve with discussion. with discussion and with like lots of counteractive questions. With that, sometimes like some of the questions also like make me wonder that why this is not the answer, and that's how we get into a answer, right? That's important. So yeah, we'll make sure that we take another class on these cages so that you know. All right, thank you so much. Have a good night. Happy to help always. Okay, as I say that it's always, these are the sample questions. Whenever like some of the questions will help us to understand the questions in the exam so that we know like how to solve the questions in the exam. So this is actually just an example. We'll always like try to take some cases on questions which are important, and by discussion we'll also know the theories and we'll also know the answers, that and that's how our knowledge will be built up. Okay, so thank you everyone for joining. Have a good night. Bye. Yeah, it will have a recording.